everyone. Dr. Gina Pritchard here, and I'm thrilled to have Dr. Todd Eldredge as my guest today. Dr. Eldredge is a cardiology epidemiologist and the author of the book, Cardiovascular Wellness Management Success Plan. I've read the book, and I think it's so timely. I want to recommend that everyone get a copy of this book and read it. Whether or not you're a healthcare provider, this book has life-saving information for you. You're going to want to get a copy and read it. But of course, Todd, you wrote it particularly for the medical professional,
right,
who is interested in upping their game in terms of saving lives from heart attack and stroke, for example, and give them real tools, not only the science, but tools to do the right thing for the patient, to save lives, improve their practice while making money doing it. A lot of people think, oh, such and such sounds good, but insurance doesn't cover it, or I won't make any money doing that. I think that's very important. And another thing I wanted to say about the book is the fact that I love that you brought in several different tools for the toolbox. In other words, we know that your area of expertise, there's many of them, but as the CEO and owner of CardioRisk, of course, you have expertise beyond any other in terms of ultrasound technology. But you don't just, this is not just a book about ultrasound. For one, you tell us your why. I love that. And you also tell us about other functional and structural and then biomarkers that are equally as important in saving our patients' lives. So anyway, I thought it was well done, very thorough. And it's near and dear to my heart, of course. As you know, the blood, sweat, and tears I put into my doctoral thesis on the subject, at least related, in terms of why aren't nurse practitioners implementing this program in widespread fashion? We're all about prevention. And you knew this before I did the study, but well over 60% simply said they just were unaware of the science. So you start with the science, which I love, can't dispute the science. And then the other important piece is that sometimes today in our broken healthcare system, the provider unfortunately doesn't have the decision-making capability. So that's a topic for another day, but you have some strategies that can be used now, whatever your practice patterns. So tell us a little bit more, Dr. Eldredge, about this book and the valuable content.
Thanks, Gina, and thank you for the endorsement. You know, we're big fans of your practice and the BaleDoneen method, of course, and I think I mentioned that many times in the book.
Yes.
I don't know of another technique out there that's better at preventing heart attacks and strokes. And so a little bit of background so that those that aren't going to take the time to read the book, that's fine. The why I wrote this is a work of love for my friends who are providers. You know, I have friends that are primary care physicians that I don't want to say they're starving because they make a living, but it is really hard. And whether you are a patient watching this or you are a provider, I want to tell you I have great empathy. You know, these guys, for those of you that don't know, are seeing 30 to 50 patients a day, which is really hard. You don't realize they don't have time to go looking at new technologies because they're so busy just trying to get through the day. This is what their healthcare system has done to them. And so unless you're seeing a concierge practice doctor, your doctor likely, or if you're the provider, you likely don't have time to invest a whole lot of energy into new technologies. And that's really what my book is about. It's an indictment on the standard of care because the standard of care is killing people. It really is. And I think the best of intentions are out there. I don't think it's anybody out there trying to say, here, let's screw the American population from healthcare. I really don't think that's happening. It's well-intentioned people that get involved in the process and have made it so unmanageable that poor physicians and guys that are providing care can't get it done. So what the book then does is says, look, here's 3 things you ought to implement in your practice. If you skip all of the other stuff, this is and of those, one test in particular that if you'll just add it to your practice will save lives and add dollars to your bottom line. If you're a patient, don't be offended by that. The more money that the doctor's bringing into his practice through, and not price gouging, but by making an honest living, the better chance you're going to have as a patient to get really good care. So there's a whole section in the book that says, here's how you monetize this and make it worth your time. But here's the short version, Gina, and you already know this science. 100,000 person year study. They don't come much larger than that in terms of clinical outcomes. This was a 10,000 person study that we followed the same 10,000 people for 10 years. And it was a group of asymptomatic patients, so we didn't know they were sick. Now, back in the 1990s, we also didn't know that this technology we're discussing was useful. We really didn't. And so we took this group of asymptomatic patients. In fact, if they had any traditional risk factors, hypertension, dyslipidemia, low HDL, any of the kind of traditional markers, they couldn't be in the study because we really wanted to observe them. So for 10 years, the study watched the same 10,000 patients, and we looked at their IMT, which is the technology we're talking about. Well, 21% went on to have an event. 21% out of 10,000. That's a lot. And the bottom line is that, oh, by the way, at the onset of the study, if I didn't mention this already, that they were asymptomatic, meaning they had none of the traditional risk factors for events. No hypertension, no hyper or dyslipidemia, no family history, no hypertension. Any of these traditional risk factors were criteria to not be involved in the study. And the reason for that is we really didn't know how effective this technology we're talking about, IMT, we didn't know how effective it would be. So we didn't, we had them all sign waivers so that they agreed to not be treated in the 10-year period. You don't want to do that in a group of high-risk patients. So notwithstanding that, 21% of these 10,000 patients, so 2,100 people went on to have a clinical event. IMT successfully predicted 98.6 of those. And what I like to tell people is I looked up, I'm not aware of another, maybe you are, but I'm not aware of another test in any genre of medicine that comes anywhere close to that high of a catch rate. Home pregnancy test I look up in the first trimester catches 97%. So this very literally is the pregnancy test for heart disease. Why wouldn't you get it done? There's no radiation, there's no needle sticks, there's no disrobing, no pain of any sort. It's a 10-minute procedure that's relatively inexpensive, even when we use it to help monetize a physician's practice. So there's really no downside to doing it. On the provider side, it gets reimbursed very well, but here's the thing that I like to caution providers about. Remember that the whole point of a reimbursement system by the AMA is we reimburse on people with known diagnostic codes. The whole ICD-10 program is a system of diagnostic codes. Therefore, what they're going to pay for are people we already know are sick. The AMA, as a rule, unless it's a test that has a tremendous amount of political pressure, as a rule does not pay for screening tests. Now, the exceptions, of course, are mammograms that had a great deal of political pressure, colonoscopies, great deal of political pressure, but for the most part, they don't really go around covering screening tests. And so the only way to get this covered is for people that are already at risk or that we know that have some disease. In the meantime, you're talking about a less than $300 test in most cases. And to do that once a year, I mean, that's a couple of nights out on the dinner and a movie a couple of nights a year. I think most people can handle that. And you would be surprised as a provider when you start telling your patients about this test, how many want to sign up and have it done. Now, I also like to tell Gina, because people hear carotid ultrasound, and there's misinformation in the marketplace. There's a great company out there, Lifeline Screening, that goes around and does carotid duplex exams. Which is now I want to clarify, they do a lot more tests than just the carotid ultrasound. They do bone density and ankle brachial and some very good tests, but I wish they wouldn't do the carotid ultrasound that they do. It's been specifically called out by the American Society of Echosonography. You shouldn't be doing duplex as a screen, and the reason is very similar. I liken that test to measuring the amount of flow of water going through a hose. Now, if you kink a hose, you have to kink it pretty far before you'll start to get a spray. If you know what I'm talking about. If you ever water your garden and you kink the hose like I do, I'm too cheap to buy a cap on it, so I kink it, right? And by kinking it, it'll create a spray. It changes the hemodynamics so that we get this spraying effect. Well, what the Doppler does is it measures the flow or the amount of water going through the vessel. Here's the problem. You have to be 50% blocked before you'll even have an anomaly. That the math doesn't work below a 50% blockage. So anything below 50%, I'm basically throwing a dart at the board and saying, well, you got some plaque, and so you're 20 to 40%, but the math doesn't work on Gladkoff's theory. So and it's 70% before you have an abnormal finding. Well, 70%, over 80% of the population that has a heart attack or stroke will have less than 70% blockage at the time they have their event. So to sit around and wait till you're 70% blocked and can fail that test is a suicide pact. So the advantage of IMT is, instead of looking through the hole, if you will, right, where we're measuring velocity and amount of blood flow, we simply measure the wall of the artery where this disease lives. The disease is not at all unlike acne. So a gross oversimplification of what we do with the carotid intima media thickness test is we use ultrasound to peer into the arteries of your neck, and we're looking for pimples. That's a gross oversimplification, right? We can see not only if you have these lesions, we can see the inflammation that always precedes a lesion. It's physiologically impossible, as far as we know, to grow a plaque without inflammation. And to the best of our knowledge, you can't have a heart attack or stroke from atherosclerosis without plaque. So from a provider standpoint, if you can arrest the inflammation here, you've saved the life of your patient, or at least extend. Listen, we all have to cross the rainbow bridge eventually, right? And so, but as a provider, if you can extend and preserve the quality and quantity of life, you've done a great job. And so with IMT, we can measure, we're accurate to 2 microns. I mean, that's smaller than a fraction of the size of your head. And so to be able to monitor year over year, it's really important to have somebody that's got reproducible results. And of course, you know, in the book, we talk about our own published research, where we showed in peer-reviewed published data, double-blinded studies, that we were accurate to 2 microns and reproducible. That means if you had 2 of our techs come and measure the same person on the same day, they would be less than a fraction of a hair of difference between them. That's the kind of reproducibility you want if you're going to use a test and incorporate it into your practice. So that was a lot of data, but what the takeaway from that, Gina, of course, is just that this is a really good test. The data is behind it. There's over 14,000 peer-reviewed journal articles last time I ran a PubMed search. And yes, not all of them are favorable. Anytime you have a technology with 14,000 peer-reviewed studies, you're going to have contrarian data. I address a lot of the most controversial contrarian data in my book. It's one of the reasons it's out there. We know that physicians don't want a sales job. They want to see all of the science. And I try to do a reasonable job of giving both kind of the pros and cons so you can make your own decision. But I think the evidence is so clear. This is a useful technology. No radiation, no needle sticks, no disrobing, no pain. Why wouldn't you use it for something that's that inexpensive? The answer is I don't know. I don't know why you wouldn't use it.
I don't know either. And of course, you compare it to angiography, which is risky, expensive, and again, tells you primarily the same thing as carotid duplex, except looking at the heart arteries for major blockages, right?
Yeah, you're running a catheter up their leg, and quite frankly, cardiologists, we can't go around running catheters up people's legs for the fun of it either, or cracking their chests open, right? You have to be far enough along to be able to justify those. And while I'm at it, you know, there's some other good tests out there. I'm not saying this is the only test. Coronary calcium score is well used. Mm-hmm. All tests, though, we have to remember, have their strengths and their weaknesses. Mm-hmm. And coronary calcium score gets compared often to IMT. I think it's a great test. I think we should be doing both. But the caution with coronary calcium score is, of course, the amount of radiation involved, anywhere from 20 to 2,000 times the radiation, depending on the machine your hospital is using. Mm-hmm. And to repeat that, 20 times 2,000 chest x-rays, that's a lot of radiation. To do it once, I think, is reasonable. To try and monitor it over time, I wouldn't touch that. Mm-hmm. But it's a good test, and there are other good tests out there. In my mind, we should be using all of them, particularly in a test in a population that's higher risk and maybe has hypertension and multiple other Framingham risk score criteria. Why wouldn't we? Right. But at the very least, if you're only going to choose one, I'm not even aware of another test out there that has better data than a 98% catch rate on a 100,000 person year study. That's pretty tough to beat.
Right. And besides those excellent statistics and the science behind it, it's applicable for that screening for a person that's in their 20s, 30s, 40s, 50s, 90s, but no diagnosis of coronary artery disease or carotid artery disease or atherosclerosis. So it's great for a screening test, but it's also very important for someone who has had maybe 1 or 2 heart attacks or a stent, because
absolutely
comes close in terms of being able to monitor that progress in reducing inflammation, like you've talked about.
You bring up a great point, Gina. You know, the American Heart Association's expert panel, okay, I mean, these are the guys that know, clear back in the year 2000, recommended CIMT for routine use in patients 45 and up. Now, our own recommendation is 30 and up, because I have 150 million, over 150 million IMP measurements in my database. I'm telling you, we see disease every day in patients as young as 31 and 32. So waiting till 45, I'm not comfortable with that either. I would tell you even younger, if you have a patient from Southeast Asia or that's of African American descent, because we see it in younger ages. The Bogalusa heart study that was done years ago, we found arterial disease in patients as young as 8 years of age. So I don't really think there's no downside because of the no radiation and no pain. There's no reason not to do it. I don't think we need to do it on everybody, but by the age of 30, I do. I think everybody, there's no reason not to get a baseline, and I think it should be repeated every 3 to 5 years in a normal patient. And I think it should be repeated every year if they have any abnormality, meaning we find inflammation or plaque. And while I'm at that, let me just address that, Gina. The report that you get back is color-coded, green light, yellow light, or red light in each of 5 areas. And that color coding gives both the provider and the patient some direction as to, well, how bad is this? If they're all green, which is what we hope for, they can come back in 3 to 5 years. The difference between 3 and 5 is what other risk factors do they have? Obviously, if you have a lot of risk factors, you got to look closer to 3. If you have no risk factors, well, another 5 years is fine. If you had yellow or red, that means you have active inflammation or plaque or both. This isn't cart you off to the cardiologist time. This is all stuff in our world that's primary care or secondary care, but it's before they see the cardiologist. So you don't have to go haul off and see the cardiologist, nothing against that. But in most cases, in every case that I can think of on our report but one, it can be treated by the primary care. And then the one exception is if we run across, should we find a patient that has greater than 50% blockage, our protocol informs the physician so that they know. We're going to tell a provider verbally, and it'll also be on a report, hey, this patient may have a blockage greater than or equal to 50%. And that's a great time to send them over to the cardiologist and have them just get a quick look to see if it's something that they can justify a more invasive procedure, or if they're going to throw them back to the primary care doc for continued management.
Excellent. That's great. I love that you say, cardiovascular disease, heart attacks and strokes, #1 killer, top cause of disability, but primarily preventable, for the large part preventable. And this is, of course, a key component of the prevention program. It truly is.
Well, the epidemiology is clear, Gina, to your point. 70% of the events, right, cerebral or cardiovascular events, are one disease, one completely preventable disease, atherosclerosis. And I believe 100% of the atherosclerosis events can be prevented. They really is one of the most preventable diseases out there. And by the way, it's responsible for 1/3 of the deaths in the U.S.
Wow. Yeah.
For a preventable disease, we need to do a better job. And it's not that we don't know how to treat it. We've known how to treat it for 40 years.
Yes.
And I don't spend any time in the book about how to treat. I throw them over the fence and say that's Amy and Brad's and people like you, Gina, to treat, because they know how. But we've known how to treat for 40 years. Our problem is we're grossly underdiagnosing and misdiagnosing patients. And so if we can just identify a greater population that's sick, we have the chance to heal them and keep them alive for a lot longer. And, that's the goal, right?
Right. Well, I think that this video, of course, will open the minds of listeners, but I think we need to change in terms of, I can't tell you how many people have looked at their CIMT report or even their angiogram report and said, well, it's small, well, it's mild. No, small things cause disastrous effects. Ask anybody that's had a 3-millimeter kidney stone, right? They're like, give me medicine, get me to the hospital. I'm dying here in this pain. Unfortunately, something smaller than that can take you out with a heart attack or a stroke.
Yeah, it's an oxymoron, a small plaque, right? It's like I had a small plane crash.
Yeah.
There's no such thing.
No such thing. It's like your analogy earlier. I'm a little bit pregnant, no, if it's
Nope.
no,
Yeah.
if it's greater than a certain cut point, it's plaque, and it's.
Well, you might have some perspective that I would not have on a dimension of our report that we hear often, but maybe you could talk a little bit about because I know you use our data. How does it change emotionally the patient's state when they see that they've got plaque, a pimple 3 inches from their brain, a soft plaque? How does it change in terms of their compliance? Because I know physicians listening to this, they never have a compliance problem. Everybody does exactly what they say all the time, right?
Right.
And we know that that's a problem, but could you maybe talk about, because I think that would be interesting for people to hear how you've been able to use our report to get to find a new gear maybe.
Right. It's such a great topic. And I'll tell you why. Because people come to get this test for many reasons. Sometimes it's because a loved one just told them to show up. They're like, okay, so-and-so said I need this test. Here I am. And other people are scared to death. They're going to have to go back to the cath lab, to the operating room, to the hospital for another stent or another heart attack or bypass. So you get the whole gamut. Then there are people that are just incredibly proactive about their health and want to take their athletic endeavors to the next level. And they're like, I can't let a heart attack or stroke take me out, so I need this test. So you get all kinds. But let me just say that most everyone, once they get the results, it is a change in their mindset. It's a shift in the way you think, because even if it's negative, if we don't find any plaque, there are so many other pieces of information that are valuable to help you stay healthy and keep those arteries healthy. But most importantly, if you do have plaque, I have had everything from people, obviously becoming very emotional, crying, fearful that they're going to have a heart attack tomorrow, which is sometimes the case. And that's why we do this test. Then others who, like I can remember one person who absolutely threw their report at me across the table and shook their finger at me and said, I can't have disease. I can't have plaque. And I'll tell you why. You have no idea how hard I've worked this last year. Vegan, marathon runner. I've sacrificed so much. And so lifestyle is incredibly important. But if you don't look, you don't know if your lifestyle is everything. Anyway, you have to come to grips with the truth once you get that report.
I don't know how we're doing for time, but there is one other point that I think particularly for physicians would be important. And Gina, you've had the chance to attend our training firsthand.
Mm-hmm.
That we do not take it lightly. It's a three-day course. Every one of the techs that work for it, because the context of this is there are a lot of people out there providing this test now. One of the benefits of expanding the knowledge about the test is everybody thinks they can do it. You've got sonographers even that with no training other than they went through ultrasound school. Well, I know where the intima media is, and so they think they get a good test. And I have to tell you, if you're using one of those providers, you're at risk. Right. Every technologist that works for me, every single one, before I'll put my name on the report, CardioRisk Laboratories, Inc., they have to undergo a double-blind performance-based certification. I know you witnessed this, Gina, that we don't guarantee passing. The fact that they've even been through our training, there's a skill involved. And until they can get within that tight parameters, they don't work for us. Mm-hmm. And maintaining it, they don't keep it forever just because they've been through it once. They have to maintain those standards. The second that we review every batch of images that come into us, and the second those standards start declining, we'll pull a certification, because we know that the most important thing that you buy as a provider from our company is reliability and reproducibility. And if I can't give those to you, if I can't stand behind those measurements that we're giving you, I really don't have much to offer that's of value. And I thought maybe because you've gone through it and witnessed, you actually, I don't remember if you went through the whole thing, but you certainly saw people close to you that went through it and how rigorous it is. It's not a walk in the park. It's 18 hours of hands-on training.
Yes, and I'm so glad that you did tackle that topic in the book, both the scanner, the reader, and the certifier. Quality measures all along the way are incredibly important. Absolutely important, because not only is the provider claiming their stake on their treatment plan for the patient on this, but the patient's life is dependent upon it. That's why it's incredibly important. And I think it's a catch-22 in that on one hand, we're thrilled that radiology centers here and there are starting to mention the plaque wall, starting to mention the wall and not just flow. but it is not good unless they send them for a high quality study like you are talking about here at CardioRisk, because it again doesn't tell us exactly where we are at baseline, and we certainly cannot compare the follow-up test in a year. We've been mentioning it, but it needs to be a high quality study on all levels. So I'm glad you also covered that in the book.
Well, good. I mean, I think we've done at least justice to what they're going to see. That's the kinds of things we talk about, and we just flush it out a little bit wider, I think is fair to say in the book. And but these are the topics that we cover. Absolutely.
So get a copy of the book and stay connected. And if you haven't had your CIMT this year with CardioRisk, call today and get your CIMT performed. Thank you so much. I really
Thank you, Gene. It was great to talk to you again.
Great to talk to you too.